So, managing the left atrial appendage, who benefits? Okay, I have to do it with this one. These are my disclosures. And if you want to answer that question, you can use two large meta-analyses. One from Europe and Australia that was published in 2015 with Marc Lemaire and Tristan Jan. And they looked at quite a few studies, and they extracted 7 of those who were eligible for further calculation. And what they were able to see is there is a favor for surgical left atrial appendage closure when it comes to reduction of stroke in the 30-day follow-up, but also at latest follow-up. And what they were also able to see, even a reduction in mortality when you close the left atrial appendage surgically in this meta-analysis. Well, there is another meta-analysis that was published last year from Massachusetts, 2018, and they looked at the 30-day mortality and 1-year mortality, and they stratified the results also to patients being in AF at the time of surgery and patients not being in AF at the time of surgery, a so-called prophylactic closure of the left atrial appendage. And they were able to see a reduction in stroke, and they were also able to see a reduction in mortality when you close the left atrial appendage surgically. And when you stratify by atrial fibrillation, there for sure is a better result if you treat patients being in AF at the time of surgery. There's still some benefit for the patients not being in AF at the time of surgery, but we all know that approximately 13 to 15% of the patients who are being in sinus rhythm at the time of surgery will end up in persistent AF after the surgery after 1 year. So there seems to be some benefit to those patients being in sinus rhythm before the procedure. So 2 meta-analyses told us that it's good to close the left atrial appendage during cardiac surgery. So to my belief, virtually all cardiac surgical patients being in AF will benefit from a closure procedure. But why is it then that the guidelines do not support us with that? These are the 2014 guidelines from the AHA, ACC HRS guidelines, and they said when it comes to left atrial appendage occlusion, they give us a 2B class indication level of evidence C. Not very good, to be honest. And why is it? Well, they tell us right away down there the inconsistency of techniques used for surgical excision and also the highly variable rates of successful left atrial appendage occlusion. So there is quite some critique on the surgeons treating the left atrial appendage. In the 2016 European guidelines, they give us a 2BB indication, which is a little bit better, but look at the one above. So if you close the left atrial appendage surgically, we have a class 1B indication not to stop anticoagulation. To me, that doesn't make any sense. Why treating the left atrial appendage and still putting the patient on a risk of any bleeding event? Well, to give you an answer on those European guidelines, they used 2 studies in order to give you that recommendation. Well, one of the studies is the LAOS-1 trial published in 2004. They used patients from 1999 to 2003. So they used a technique that was only available at that time, and that was stapling or just oversewing the left atrial appendage. And they looked at more than 1,000 patients. At least 77 patients made it into the study. And what the authors were able to do, the epicardial suture of the left atrial appendage, they had 57% failures in 30 patients, 57% failures. Stapling, they had 38% failures. And what also happened is that one of the patients had a stroke perioperatively. 2 patients had a stroke, and one of them perioperatively. So we don't even know whether that is because of the treatment of the left atrial appendage. So the authors concluded that the complete occlusion of the left atrial appendage is challenging, and with that we need more randomized trial. Well, James Cox gave a very robust answer. He said that this study only documented that surgeons at that time were not able to close the left atrial appendage reliably. That's all this paper showed. And the second paper that was used in the guidelines was this paper the Prague 12 study, a randomized study with 214 patients, and they wanted to see if surgical ablation therapy is possible and successful or not. That was the main endpoint. Second endpoint was stroke. Well, they had a very nice editorial to this paper from Hendricks from Leipzig, and he said that the Prague 12 study has had significant methodological limitations and leaves more questions than answers. And what he also said is, instead of publishing these bad data, the surgeons should intensify more clinical research, and they should improve the quality of care in their patients being in AF. So the guideline committee used 2 papers, to my belief, that were not the best papers. But those were the only one around. You can only use papers that are out there, right? So why is it still that surgical closure of the left atrial appendage seems to be a problem? Well, one of the problems is this one, recanalization of a closed left atrial appendage. You can see here a mitral redo procedure, and what you see on the left upper side is a recanalization of a formerly closed left atrial appendage. And this is from our center in Lübeck. This is a patient who has had an open left atrial appendage before the procedure, a closed one after the procedure, and this happened 4 weeks after the procedure, a recanalized left atrial appendage, which is bad. If you treat the left atrial appendage, it ought to be closed all the way, not this one. This is dangerous. This is a nice study from California, published 2 years ago, and they were able to show that if you have an incomplete closed left atrial appendage, you have a neurological problem. So incomplete closure of a left atrial appendage has an answer of neurological problems over time. And this is a paper probably everybody knows from Kandarian. They looked at different surgical techniques and the results of their techniques to close the left atrial appendage. And you can see the best solution seems to be excising. Right? If you excise the left atrial appendage, the problem should be gone. Suture exclusion and stapler exclusion at that time, the staplers are different nowadays, had some very bad results with respect to thrombus formation or recanalization of a left atrial appendage. And the authors saw a decreased incidence of stroke in patients with successful left atrial appendage closure. Well, in 2015, a group looked at patients who were scheduled for cardioversion after a surgical left atrial appendage and MACE procedure. And they all do TEEs before they do the cardioversion, right? And what they were able to see is that even in the patients who have had an amputation, an excision of the left atrial appendage, there was still clot formation, or there was still systemically accessible thrombus rate, and they had to cancel cardioversion. So excision is not always the best solution. It's only the best solution when you do it properly, all the way down to the base. So to my belief, and we published that last year, to my belief, you either excise the left atrial appendage all the way down to the base, don't leave a stump that is larger than 5 millimeters, or you have to clip the left atrial appendage. And the inventor of the clip is in the audience, Dr. Gillinov, and this is real time. This only takes you approximately 30 seconds to 1 minute to really close the left atrial appendage properly, right? The assistant pulled slightly on the left atrial appendage. You go down all the way to the base. You can check for the circumflex artery, no problem there. And you just then cut, and that's it. And this is 30 seconds, right? So all the way down to the base. And this is what it looks in the acute phase, and this is what it looks like after 3 months. So all the way down to the base, nice, smooth, no foreign body within the heart. So with all this knowledge that you have to do it properly, does that change the guidelines? Well, something has happened over the last 2 years when it comes to publication. This is the first large publication that came out in 2017, and they looked at the STS database. They looked at 15,000 patients, and they matched a group of patients being treated surgically with a left atrial appendage and patients not being treated, and they saw a significant impact when it comes to reduction of cerebrovascular events in patients being treated surgically with a left atrial appendage. But they paid a high price, right? So they had more tamponade in the left atrial appendage treatment group, they had more pericardial effusion, and they had more in-hospital death. So there's some positive, but also some negative data out of that paper. Well, then this paper came out in 2018, and again, they looked at almost 10,000 patients, and they asked for readmission of thromboembolism among patients who got treated surgically on the left atrial appendage. And they looked at quite some sick patients. 50% of the patients were in persistent AF. They were quite obese, actually, and they had a high CHA2DS2-VAS score. And with respect to readmission for thromboembolism, they were able to see that there was a significant decrease in readmission in patients being treated, also a significant decrease in mortality and in the combined endpoint, but no difference with respect to hemorrhagic stroke. Publication number 2. Publication number 4 also came out in 2018, and they looked at the association of surgical LIA occlusion with subsequent stroke and mortality among those patients. And again, they were able to show in patients being in AF at the time of surgery a significant reduction in stroke. Is there a pointer here? No. Yes. These are the patients being in AF at baseline, significant difference. Interestingly, they didn't see a difference between the patients not being in AF at baseline, being in sinus rhythm. And they also saw that difference with respect to mortality. And in a subgroup analysis for stroke in the propensity matched patients, 8,000 patients again, it was all in favor of left atrial appendage occlusion. So that was a retrospective, large, big data publication. And then we had this nice little Danish study, a prospective randomized trial of 200 and something patients. And they looked at patients being in AF and in sinus rhythm, and they randomized them to either closure of the left atrial appendage or not. And then they looked at neurological events over the time coming. And this is the surgery type, so with AVR, CABG, aortic surgery, mitral valve surgery, so everything we do in the OR every day. And the results were quite convincing, actually, that after 6 years, a significant decrease with respect to cerebrovascular accidents. So 4 publications, good data, 1 prospective randomized trials gave us a different answer to treatment of left atrial appendage. And this resulted in a change of guidelines. Just came out in January this year. So the American guidelines now changed from a 2BC to a 2BB. And this is because there was new evidence, and I just showed you the evidence. And by the way, it is exactly the same recommendation for the surgical treatment of left atrial appendage as for the interventional aspect of of left atrial appendage treatment. So therefore, for the ones who have a standalone program, there's no need anymore, or there's no possibility anymore for the cardiologists, for the EP guys, to tell us that their procedure has a better classification when it comes to guidelines, at least in the US. And I hope that for the European guidelines, this will change as well. So it's exactly the same for the 2 approaches, surgically and interventionally. So do all patients benefit of surgical left atrial appendage management? I believe yes, but only if you do the right technique, and that is excising all the way down to the base or clipping all the way down to the base. Thank you.